It's mania and bipolar disorder. This is a case. A 29-year-old man is brought to the emergency department in a drunken stupor. He is accompanied by his wife, who states that he hasn't been himself at all for the past few months. According to his wife, he was evaluated for depression by his personal physician about 3 months ago and was started on selective serotonin reuptake inhibitor. He responded quite well to this therapy over the subsequent 2 months. He started feeling so good and so energetic that he stopped taking his medication. He found that he needed less and less sleep to the point where he is now only sleeping 2 to 3 hours a day. He has been showering his wife with very expensive gifts. He has also started drinking heavily. His work has suffered, and his boss said that he is in danger of being fired. Other than being drunk, his physical examination and blood tests are normal. Now coming to what is the diagnosis. He is admitted to the psychiatry unit with a diagnosis of bipolar disorder and was started on lithium. Now the questions are, what is the mechanism of action of lithium? What are the common side effects of lithium? What is the mechanism of lithium-induced polyuria? Now, what is mania? Mania is a period of elevated, expansive, or irritable mood with coexisting symptoms of increased energy and goal-directed activity and decreased need for sleep. The important symptoms of mania are daydreaming or racing thoughts, highly energetic, inflated self-esteem, feeling of over-exhilaration, and difficulties in sleeping. So what is bipolar disorder? So a person with bipolar disorder will have mood swings from the highs of mania to the lows of depression. So there are two types of bipolar disorder, bipolar 1 and bipolar 2 disorder. In bipolar 1 disorder, the person will have at least one episode of extreme mania lasting more than a week. And the depression will be milder than other bipolar types. In bipolar 2, patient will have symptoms of mania, which is a hypomania, that is a milder form of mania lasting at least 4 days. And there will be at least one depressive episode broken up by periods of mania. So in bipolar 1 disorder, the person will have mania and major depression. Whereas in bipolar 2 disorder, patient will have hypomania and episodes of depression. Now, classification of drugs for mania and bipolar disorder. So the most important drug is lithium carbonate. Then few anticonvulsants having effect in mania and bipolar disorder are sodium valproate, carbamazepine and lamotrigine. Then atypical antipsychotics like olanzapine, risperidone are also used. Now, the history of lithium. It was discovered by an Australian psychiatrist, Cade. So he first used lithium for bipolar disorder. So during the Second World War, Cade was a prisoner and he observed his fellow inmates in prison and found that they had mood oscillations. He was a good scientist also. So he collected urine from manic patients and mentally healthy persons and injected them into guinea pigs. And he found that person injected with urine from manic, guinea pigs injected with urine from manic patients had harmful effects. He thought urea or uric acid in urine is responsible for this. So later he found that urea did not produce any effect and the uric acid as the toxic compound. So he did experiments more on uric acid. For that he wanted to dissolve uric acid. And in order to dissolve uric acid, he added various substances. And one substance was lithium. And so he injected lithium urate and he found that there is a calming effect in guinea pig. So he self-administered lithium to estimate the safe dose and injected it into 10 manic patients. And he found that their symptoms were improved. And he reported it in this article, Lithium Source in the Treatment of Psychotic Excitement, which was published in Medical Journal of Australia. Now, what is lithium? Lithium is a small monovalent cation. It's used to suppress mania. It also exerts a prophylactic effect in bipolar disorder. It is a standard anti-manic and mood stabilizing drug. Coming to the mechanism of action, lithium produces its effect on electrolyte and ion transport. Lithium can partially replace sodium and substitute for sodium in the membrane. It also affects exchanges involving sodium, but it is unable to maintain membrane potential. So this is a dopaminergic neuron, this is a presynaptic neuron, and this is a postsynaptic neuron. So lithium can interfere with the release of dopamine. And lithium also, in the postsynaptic neuron, it interferes with the recycling of inositol. Lithium has got an important effect on second messengers. Lithium inhibits the hydrolysis of inositol 1-phosphate by inositol monophosphatase. So the supply of free inositol for regeneration of membrane phosphatidyl inositodes is interfered. So this is the source of IP3, inositol triphosphate and diacyl glycerol. So the free inositol is decreased. So inositol triphosphate and diacyl glycerol is decreased. So you can see inositol phosphate, monophosphate is converted into inositol by inositol monophosphatase enzyme. And this gets converted into phosphatidyl inositol phosphate, phosphatidyl inositol bisphosphate, which is acted upon by phospholipase C, and diacyl glycerol and inositol triphosphate is generated. Diacyl glycerol activates protein kinase C and it is involved in response. Inositol triphosphate causes calcium mobilization. So this DAG and IP3 are the second messengers that mediates the cellular responses due to G protein coupled cholinergic receptors, alpha adrenergic receptors, serotonergic receptors. So inositol monophosphatase is inhibited by lithium. So the regeneration of free inositol is inhibited. So the second messengers IP3 and DAG are inhibited. So those responses get blocked. This predominantly affects the hyperactive neurons in manic state. Now the effect on neurotransmitters. Lithium can decrease the noradrenaline and dopamine levels in the brain. It can also modify the glutamate and GABA concentration in the brain. Now the actions in various systems. First, in the central nervous system, lithium does not have any acute effect in normal individuals or individuals with bipolar disorder. Lithium is not a sedative or a euphoriant, but on prolonged administration, lithium can produce mood stabilizing effect in bipolar disorder. In acute mania, it takes 1 to 2 weeks for the action to be established. Other actions of lithium. Lithium can inhibit the actions of antidiuretic hormone on the distal tubules. So the renal tubules won't respond to antidiuretic hormone. As a result, a diabetes insipidus-like state will be created. And lithium will inhibit the release of thyroid hormones. So thyroid gland won't respond to thyroid stimulating hormone. So this occurs due to the uncoupling of receptor from the G protein. Also, lithium can produce an insulin-like action on glucose metabolism. Also, lithium can increase the WBC count. The pharmacokinetic properties. Lithium is completely absorbed orally. The peak level is obtained in 1 to 3 hours. The elimination half-life is 24 hours. 95% of lithium is excreted through the kidney. Rest is excreted through saliva, sweat, and breast milk. Kidneys handle lithium the same way as sodium. Now coming to the plasma concentration, lithium has got a very narrow therapeutic index. Because of this, regular monitoring of plasma concentration of lithium is necessary. For episodes of acute mania, the plasma concentration of lithium has to be maintained between 0.8 and 1.2 milliequivalents per liter. Whereas for maintenance treatment in bipolar disorder, the level has to be between 0.5 to 0.8 milliequivalents per liter. Toxicity occurs when the plasma concentration is more than 1.5 milliequivalents per liter. So the adverse effects, fine tremors are occurring 50% of the individuals even at rest. Then nausea, vomiting, mild diarrhea occurs. In order to decrease the GI effects, start at a low dose. And because of the nephrogenic diabetes insipidus, the patient will have thirst and polyuria. CNS symptoms occur when there is increase in plasma concentration. This include seizures, motor incoordination, coarse tremors, ataxia, nystagmus, slurred speech, coma, mental confusion. If the plasma concentration is more than 2 milliequivalents per liter, patient will develop muscle twitching, drowsiness, delirium, coma, convulsion, vomiting, diarrhea, albuminuria, hypotension, and arrhythmia. So the treatment of lithium toxicity, there is no antidote available. Osmotic diuretics and sodium bicarbonate infusion is given. This will promote the excretion of lithium. And if the plasma concentration is more than 4 milliequivalents, then hemodialysis has to be done. Now coming to the adverse effects. So because of the effect on thyroid gland, the lithium will produce goiter and hypothyroidism. So the mechanism is there is inhibition of release of thyroid hormone. Thyroid gland won't respond to thyroid stimulating hormone. As a result, there will be decrease in thyroid hormones T3 and T4. So there is feedback stimulation from the pituitary. TSH secretion occurs and that will lead to goiter. So this can be managed by thyroid hormone supplementation. Then lithium produces teratogenic effects, fetal goiter, floppy baby syndrome or hypotonia, and Epstein's anomaly can occur. Then it is contraindicated in breastfeeding because it is restricted to the breast milk. The miscellaneous adverse effect include increased incidence of acne, weight gain, and dermatitis. Lithium can cause reduction of T wave amplitude, and higher level can depress the SI node and AV nodal conduction, can predispose to arrhythmias, and lithium is contraindicated in sick sinus syndrome. So to summarize, the important adverse effects of lithium are it can produce GI upset, nausea, vomiting, diarrhea. It can alter the thyroid function. Then it can produce nephrogenic diabetes insipidus. It can produce tremors. It can produce CNS adverse effect, mental confusion, seizures, slurring of speech. It can produce arrhythmias. And the drug interactions, diuretics like thiazide and furosemide will cause sodium loss. So there will be increased proximal tubular reabsorption of sodium as well as lithium. That will lead to lithium toxicity. Lithium can increase the insulin-induced hypoglycemia. Tetracyclines, NSAIDs, and ACE inhibitors can cause lithium retention. Now, coming to the uses, lithium is used in acute mania, but the response is slow. The onset of action is slow, and the control of plasma level is difficult. So it is not a drug of choice for acute mania. Atypical antipsychotic can be given orally or intramuscular injection, along with or without a potent benzodiazepine like clonazepam or lorazepam for the acute treatment of mania. Lithium is started only after the acute episode is under control. Maintenance treatment has to be done with lithium for 6 to 12 months. Then second indication is in bipolar disorder. The plasma concentration has to be maintained between 0.5 and 0.8 milliequivalents per liter. This found that lithium can lengthen the interval between mood swings, and it can also decrease the episodes of mania and depression. Lithium is also found to be effective in recurrent unipolar depression. So lithium is tried in various neuropsychiatric disorders, and it is found to be effective in treatment of cluster headache and also in resistant non-bipolar major depression. Now about lithium carbonate salt. So the carbonate salt or citrate salt is less hygroscopic and less GI irritant than lithium chloride. So carbonate or citrate salt is preferred. And the starting dose of lithium is 300 to 600 milligram thrice daily, and the maintenance dose is 300 milligram thrice daily. The dose must be individualized based on the serum level and clinical response. Now, other drugs that are effective in bipolar disorder are the anti-epileptic drugs like sodium valproate. Sodium valproate is a first-line drug in mania, and it's also useful in bipolar disorder. And it acts fast and it has got a better safety profile compared to lithium. Divalproex is the complex of valproic acid with better gastric tolerance. So sodium valproate can be given in combination with an atypical antipsychotic in the treatment of bipolar disorder. And sodium valproate is an effective prophylactic agent in bipolar disorder. Patients with rapid cycling pattern of mania and depression benefit with sodium valproate. The second drug is carbamazepine. Carbamazepine prolongs the remission in bipolar disorder, and it is very useful in mania. The effective doses have to be gradually built up. So it's not effective in acute mania. Then it has got a strong enzyme inducing property, so it causes a lot of drug interactions. The next anti-epileptic effective is lamotrigine. Lamotrigine can be used for prophylaxis of depression in bipolar disorder. It has got a good tolerability, and it can be combined with lithium also. Atypical antipsychotics that are effective in bipolar disorder are olanzapine, risperidone, aripiprazole, and quetiapine. Aripiprazole is free of metabolic side effects. So these four drugs, with or without benzodiazepine, is the first line drug for control of acute mania. Lithium has got slow onset of action. So for acute mania, the first line of choice is these atypical antipsychotics with or without benzodiazepine. If urgent parenteral therapy is required, then intramuscular olanzapine or haloperidol can be given. Aripiprazole can be used for treatment of mania in bipolar 1 disorder, and olanzapine is effective as maintenance treatment of bipolar disorder. A typical antipsychotic plus valproate or lithium can be used for acute and maintenance phase in bipolar disorder. Now coming to few MCQs based on this topic. Which mood stabilizer is completely renally eliminated and may be beneficial for patients with hepatic impairment? So the correct answer is lithium. Which agent is best known to have the side effect of decreasing the thyroid function of the patient being chronically treated with this agent? Carbamazepine, lithium, valproic acid, chlorpromazine, lurasidone. Correct answer is lithium. A 30-year-old male patient is on drug therapy for a psychiatric problem, complains that he feels flat and that he gets confused at times. He has been gaining weight. As he moves his hands, you notice a slight tremor. He tells you that since he has been on medication, he is always thirsty and frequently has to urinate. The drug he is most likely to be taking is lithium. Patient has got tremor and patient has got symptoms of diabetes insipidus. Which statement concerning the use of lithium in the treatment of bipolar affective disorder is accurate? Ingestion of foods with high salt content enhances the toxicity of lithium. Lithium usually alleviates the manic phase of bipolar disorder within 12 hours. Lithium dosage need to be decreased in patients taking thiazides. Since lithium does not cross a placental barrier, it is safe in pregnancy. The population rate of lithium is equivalent to that of creatinine. So here the correct answer is C. The lithium dosage may need to be decreased because there is chance of lithium toxicity in patients on thiazide serum lithium. The therapeutic action of lithium is thought to be caused by direct inhibition of which of the following: inositol monophosphatase, inositol triphosphate, diacylglycerol, muscarinic cholinesterase. The answer is inositol monophosphatase. Which of the following is the most likely adverse effect of lithium therapeutic doses? Answer is GI dysfunction. So that's all. Thank you.